Good afternoon, everyone. My name is Julia Schneider, and I am on the Chronic Disease and Prevention team here at the Association of State and Territorial Health Officials. I would like to welcome you to today's interactive webinar, The Maryland Department of Health and Mental Hygiene Works with Partners to Support Million Hearts. This webinar is the first in a series of Million Hearts webinars being hosted by ASTHO with sponsorship from CDC's Division for Heart Disease and Stroke Prevention. The objectives of today's webinar are to highlight how one state health agency is working to support Million Hearts to prevent 1 million heart attacks and strokes by the year 2017. To discuss innovative partnerships that will help state and territorial health agencies support Million Hearts, and to catalyze the momentum of ASTHO's presidential challenge to advance the reintegration of public health and healthcare to support Million Hearts. First, I will provide a little bit of background on ASTHO's work on the Million Hearts Initiative. ASTHO is focusing on efforts to enhance collaboration around the ABCS, aspirin, blood pressure, cholesterol, and smoking cessation, which you will hear more about from Dr. Wright. A key focus of this project is the role of public health in linking with clinical care to advance the ABCS. We have a number of resources that we are developing that will be available on our prevention page this summer. This includes recommendations from an expert roundtable that was held on May 15th to identify key strategies for the role of public health in supporting this effort. We are also collecting case studies from several states that showcase how public health is partnering with quality improvement organizations, medical societies, and other healthcare partners to support Million Hearts. These case studies will also help to inform our President's Challenge. Our current President, Dr. Jose Montero from New Hampshire, is challenging states to advance the reintegration of public health and healthcare. Dr. Montero has challenged each state health official to identify one example from their state or territory that demonstrates successful integration of public health and healthcare delivery. We are collecting state stories from every state, and you can submit your story at astho.org/success. All of this information, including a recording of today's webinar, will be posted to our prevention page at astho.org/programs/prevention over the next few weeks, and we will be sending out an announcement through our newsletter. If you would like to subscribe to our primary care and prevention newsletter, my contact information will be on the last slide, and you can email me. At this time, I'd like to introduce our esteemed panel of experts that will be speaking with you today. I will introduce them briefly, then all of the speakers will present their slides. If you have a question, you are welcome to post a comment in the Q&A chat section of your screen at any time during the webinar. For those of you joining us over the phone, you will have the opportunity to ask questions at the end of all the presentations. Following today's webinar, we will also be providing a link to an evaluation that will help guide future webinars in this series. First, Dr. Janet Wright will offer a welcome. Dr. Wright is the Executive Director of the Million Hearts Initiative, which is co-led by CDC and CMS. Before joining CDC in 2011, Dr. Wright served as Senior Vice President for Science and Quality at the American College of Cardiology from 2008 to 2011. Prior to her role with the ACC, Dr. Wright practiced cardiology for many years. Our next speaker will be Dr. Laura Herrera, who is the Deputy Secretary for Public Health for the Maryland Department of Health and Mental Hygiene. She oversees local public health, prevention and health promotion, health systems and infrastructure, vital statistics, and laboratory administrations, along with the Department's Office of Preparedness and Response and the Chief Medical Examiner. Our third speaker will be Dr. Frida Wadley. Dr. Wadley was the State Health Officer of the Tennessee Department of Health from 1995 to 2003, served on the board of the Public Health Foundation for many years, and has been a member of ASTHO and its Alumni Association as well. In 2003, she joined the Delmarva Foundation. She joined the Delmarva Foundation as Medical Director. In 2010, she became the CEO of Quality Health Strategies, which is the parent company of Delmarva Foundation. Our final speaker is Dr. Donald Schell. Dr. Schell has 18 years of experience in the field of public health, serving at both the state and local level. He's currently the Director of the Cancer and Chronic Disease Bureau in the Maryland Department of Health and Mental Hygiene. He's responsible for the oversight of the Center for Tobacco Prevention and Control, the Center for Chronic Disease Prevention and Control, the Center for Cancer Surveillance and Control, and the Office of Oral Health. After Dr. Shell's presentation, Dr. Wright will lead a facilitated discussion, and finally our speakers will take questions from the audience via chat and phone. I will now turn it over to Dr. Wright for a welcome. Dr. Wright?
Thank you so much, Julia. And I express gratitude from the entire Million Hearts team to ASTHO. You're such a valuable partner in bringing public health and healthcare together. And it's a delight for me today to sit on a virtual panel with Drs. Herrera and Watley and Shell. Maryland has really raised the bar and shown us all how integrated public health and healthcare can come together to make change. So I want to quickly walk through Million Hearts just so that we're all on that proverbial same page. So I'll ask to go to the slide that's entitled Heart Disease and Stroke. I think it's clear to all why the federal government and then states and local groups, public and private, together would focus on cardiovascular disease. Remains the #1 cause of death in the country, men and women, over 800,000 deaths a year, and very costly, not only in dollars, but of course in the loss of our family members and those with whom we work. It's also the place where racial disparities show up. African Americans, for example, lose 14 months of life to cardiovascular disease. So on the next slide, you'll see another reason we would gather around a single condition, and that is that we know what works. We know that aspirin for those at risk, blood pressure control, cholesterol management, and smoking cessation, when performed at high levels, reduces the risk of heart attack and stroke profoundly and in a short period of time. And yet you see on this slide that we're not yet achieving even 50% at the population level on these really basic measures. Another good reason for us to focus on the ABCS and see results quickly. On the next slide, and I'll ask the person who's advancing those slides to pop up each of those elements in the framework for Million Hearts. These are identified as key components of our program. It is both focal and more comprehensive. On the left side, you'll see that the efforts directed with and toward healthcare professionals and systems is in getting excellent in those ABCs. Making them a priority, using health IT to support that work, and then making sure that the ABCs and incentives and appropriate team members are embedded in the new models of care as they're launched and as we learn from them. Over on the right side, you see the efforts that are directed more at the population level and more traditionally public health work. One is reducing the smoke-filled air, so really increasing the availability of smoke-free spaces. Working with food companies to improve access and availability of lower sodium food choices and eliminating trans fat. But on the next slide, you'll see, and 2 clicks there, what we're really trying to do is to integrate the efforts of public health and healthcare. How can the assets, which are unique and complementary, be brought together? And you're going to see an outstanding example of that today in the presentations from my Maryland colleagues. So we'll move quickly to the slide that shows lots of faces. We are still looking for good ways to visualize this newly integrated effort across public health and healthcare. My own favorite, working favorite, is an emulsifier. I think that's what Million Hearts is doing, is bringing somewhat oil and water together for good. On the next slide, here are the lessons that we've learned so far. Public health and healthcare. Set a table big enough for experts that you might not know. Bring an open mind to those discussions. You will hear that in the Maryland work. And really importantly, bring your data. Those data and the analysis of those data can help you identify where the common goals should be. But really embrace the fact that these two worlds are different with different and complementary assets so that you execute strategies by sector. Who's the best positioned to execute this strategy? Monitor the progress and share the results liberally. And the other thing to do liberally is to celebrate every single step forward that you make together. So I will ask you to move to that last slide. I'd love to have all of you on this call take the pledge on our website. Those that you belong to organizations that may want to become partner, I'd encourage you to follow that pathway. And most importantly, continue to take care of your own hearts and those of the ones you love. So, my pleasure now to turn it over to Dr. Herrera, Deputy Secretary of Public Health Services in the Department of Health and Mental Hygiene in Maryland. Laura.
Thank you, Dr. Wright. If we can advance. So I'm just going to spend a few minutes talking about the infrastructure and capacity that we have in place that have allowed us to be successful in implementing Million Hearts, some of which started before delivery reform efforts. But if we start over in the brown area, looking at public and private payers, we have worked with Medicaid over the last year looking at their value-based purchasing measures for the inclusion of blood pressure control less than 140/90, and have been successful now in getting that as a measure included as something that they assess the managed care organizations in the state of Maryland on. In addition, as part of ACA, we've been working on implementing our health benefit exchange entitled Maryland Connection, and as part of working with the exchange and the qualified health plans and the essential health benefits, we've also been exploring things such as value-based insurance designs to ensure improved outcomes for persons living with hypertensive, let's say eliminating copays for antihypertensives. We've been working for the Institute for Healthiest Maryland at around 1 o'clock in the blue, and really they support our SHIP local health improvement coalitions to not only provide technical assistance around Million Hearts, but also look to the research and look to see from the research what can be translated into public health practice. We have our CHRIS, which is our State Health Information Exchange. They are currently connected to all 46 hospitals, acute care facilities in the state of Maryland, sending real-time admission, discharge, and transfer information. So for those patient-centered medical homes that are working and hospitals that are working with CHRIS can get real-time alerts to patients with hypertension and other illnesses that can then assist in discharge planning and coordination of that care. Our state health improvement process is a local our state health improvement process, which looks at 6 vision areas across 39 measures, which really looks at whose aim is to increase life expectancy as well as reduce disparities. And with those SHIP measures are local health improvement coalitions. In the state of Maryland, we have 24 counties and 18 local health improvement coalitions, some of which are regionalized as opposed to at the county level. But what they do is work to implement our state health improvement process, and based on the needs of their community, work to address the measures identified as part of SHIP. And almost all 18 local health improvement coalitions have identified Million Hearts and heart disease as a priority measure. In September, we submitted a state innovation model testing grant, and were awarded $2.4 million to plan a state innovation model, which we're entitling our community integrated medical home. And to echo Dr. Wright's comments about the integration of public health with the healthcare system, we think this is a unique opportunity to leverage what public health does well in the community and tie it to the healthcare system. And key to that is certainly Million Hearts as the measures that we think about rolling out. We have health enterprise zones down at around 5 o'clock, which is a legislation that was passed in 2012 that it identifies high-risk areas on a number of different measures, and the goal is to address disparities, and certainly cardiovascular disease around the state of Maryland has been identified, given the disparities, as priorities for the 5 health enterprise zones currently named. And lastly, the Health and Quality and Cost Council, and through the Wellness and Prevention Subcommittee has made Million Hearts, in addition to employee wellness, a priority. We have multiple other initiatives, including accountable care organizations and patient-centered medical homes, all of which are including different measures: hypertension, blood pressure control less than 140/90, LDL less than 100, but all have recognized the importance of the ABCs and are including either clinical clinically based outcome measures and or process measures that move Million Hearts forward. These are just some of the initiatives, and Dr. Schell will go in more detail through some of these in his presentation, but our next speaker today is Dr. Frida Wadley from the Delmarva Foundation. Dr. Wadley?
Thanks, Laura. Good afternoon, and it's a pleasure to be here with Dr. Herrera, Dr. Schell, to talk about how health departments and quality improvement organizations can be partners. And it'd probably be good if I start with talking a little bit about what is a quality improvement organization, or a QIO. There's an old saying in public health that when you've seen one health department, you've seen one health department. And the same might be true for quality improvement organizations. But they do have some things in common. For example, we're all funded by CMS. Each state has a contract. Our purpose is to improve healthcare quality and to protect Medicare beneficiaries. And we work with providers to improve healthcare quality. We don't provide services. And it's important to note that providers don't have to work with us. It's a volunteer association. And so usually you have to have pretty good relationships with providers. But we're different in many ways too, because we often have many contracts or even other lines of business with these organizations, and some are very big, some are small. Each has its advantages and disadvantages. Needless to say, the larger they are, the more resources they may have to bring to the partnership table.
Dr. Wadley, this is Julia. Can you speak up just a little bit? We're losing you just a little bit.
Okay. And then if they're small, they may be easier to form a relationship with. We've heard a lot about the public and private health sectors and the gap in between those. In fact, an IOM report a little over a year ago talked about that great divide. And it's a shame because our overarching mission is really the same. We are to improve the health of the people we serve. Yes, the method and work's different because for the private sector, they see individuals and primarily are geared toward treatment, whereas public health thinks of populations and it's weighted more on preventions. But just because they're different doesn't mean there is not a really opportunity for synergy if they integrate. And at this time, there's probably been never a better reason for them to come together. You can't pick up an article about healthcare reform unless you see the term population health management. Now, you would think that they'd found something entirely new. For those people that have been in public health, we wonder where everybody's been for so long. But if you read carefully, sometimes you'll see that people have different meanings for this. To me, there's four basics of it. First of all, yes, populations instead of individuals. But secondly, you need to know your population and maybe subpopulations. Third, yes, you need data to know your population. And that's where a lot of the people stop with their meaning. But if you really want to get the management part, then the fourth part is very important, and that is you're going to have customized strategies for your population to really get to management. So to me, the bottom line is population health management has been rediscovered, so to speak, but it could help close the gap between the public and private health sectors. So what can public health and a QIO gain by working together? Well, first of all, we both have different types of data. And never before has data been so desirable as when people are trying to learn what's really going on in their communities and what are their health needs. Public health has a lot of great data sets. In some states it's more integrated by community than others. And then QIOs have Medicare claims data. And although there might be some limitations by CMS about how they use that data without permission, you put those two together and you have a really rich source of data. QIOs can bring expertise in data analytics. And having been at a health department, I know that sometimes we were limited in that expertise. But then public health can come to the table and they have all that knowledge about their population and what works in their population. QIOs bring contacts in the healthcare community, whereas public health can bring all of their contacts and partners at the community level. We each bring a new perspective to problems, whereas a QIO might bring a healthcare perspective. Public health can bring more of a socioeconomic perspective to the problem that you're dealing with. And then of course we bring different strategies. And the beauty is maybe when you merge those strategies, when you think a little bit differently about what you might achieve together. So some people may think that I'm dreaming when I think the stars are aligning for public health and the private sector to come together. But just think of it this way. Today we're actually seeing hospitals, accountable care organizations wanting to do community health assessments and wanting that data. We see primary care providers being taught about the patient-centered medical home model. Within that model is a population health management component, and that's one of the most difficult parts for them to really accomplish. And then you can look at community health workers, group patient education sessions, alternative sites for services. These are things that public health have talked about for years. But only recently has the private sector started to consider how these may be strategies for improving quality and yet decreasing the cost of healthcare services. So how do you go about building the relationship between public health and your QIO the same way you do anything else? First of all, you need to meet every now and then and not just wait until you're asking something of each other. Find ways to avoid duplication of efforts. What are you doing? What am I doing? And if we don't duplicate, maybe we can actually do more. You can always find a similar interest because we're always interested in chronic diseases. And then learn a key contact at the other organization so that you feel quite comfortable in calling them up. But let's talk about what happened after we formed this relationship, and it was over several years. What happened with our Million Hearts Symposium? We got together, talked about what we could do, what was easier for one, what was harder for the other. And the way it came down is that the QIO, Delmarva Foundation, did the event planning, site arrangements, registration, got the speakers for the healthcare track sessions, printed the materials, but then public health did all the marketing to all of those groups, provided the funding for food, and also arranged for the speakers for community worksite schools and the child care sessions. So what was the result? Great results. In fact, we started planning for 200 participants. The demand was so great that we had to shut down at 300. And then right before the conference, we found a way to expand, and we opened up again, and we got 400 participants. Now, that's actually double of what we had thought we were going to do in the beginning. We also learned about the other organizations' resources and capacities. That's important because the next time we want to do one of these, we'll already be ahead of the game. You'll also like to hear that a lot of this planning was done virtually. It didn't take traveling to one place or the other. And that planning virtually will happen if you already have an established relationship. The audience was more diverse. You didn't have just community in one group seeing community. You had providers there, you had community groups, and they could exchange and hear others' opinions. But also you planned for both, so your sessions were more comprehensive and more creative. We felt the outcome was fantastic. So whether for the Million Hearts Initiative or another project, there are a lot of great reasons for public health and QIOs to build a strong partnership. And now I'll turn it over to Maryland's Department of Health and Mental Hygiene's Dr. Donald Schell to talk about Maryland's work on Million Hearts Initiative.
Well, thank you. Thank you, Dr. Wadley, and good afternoon, everyone. This is Don Schell here in Maryland, and I want to thank all of you for participating. Definitely want to thank CDC and CMS and Dr. Wright and Dr. Herrera and Dr. Wadley for all of the comments that we've heard thus far. So in our presentation today, we're going to attempt to show how Maryland has worked to integrate public health and health care. There have been some conversation about collaboration and linking of public health to clinical care. I think Janet mentioned in her presentation some comments on setting a big table and keeping an open mind and executing strategy and monitoring progress, and we'll show in our presentation how we've done that. And then I think the critical comments that Dr. Herrera and Dr. Wadley made about the efforts, the multifaceted efforts, and how we all want to improve health and the health of our populations together. Before you is a map of the state of Maryland. On the right side of the map is Delaware and the Atlantic Ocean. Over on the left side of your map is West Virginia and Virginia. And for the most part in the state of Maryland, and in the center of the map, that little square you see is the District of Columbia. Maryland is a very diverse state. And in the state of Maryland, we know that, particularly from our data, that about every 33 minutes, one person in Maryland dies from a heart attack, a stroke, or another cardiovascular disease. We have seen a decline in our mortality from cardiovascular disease, but from 2005 to 2008, we've seen an increase in our prevalence of coronary heart disease. And so in the state of Maryland, we understand that there is a significant amount of work to do with cardiovascular disease, and we wholeheartedly agreed with the approach taken from Million Hearts and wanted to participate. In looking at the data about how important it is for both public health and private health to focus on cardiovascular disease, hypertension, and stroke, we looked at our behavioral risk factor surveillance data from 2011. And the top slide, the top bar graph shows a person without diabetes and then a person with diabetes and the prevalence of heart attack in adults with these risk factors. So by far, without these risk factors, the prevalence of heart attack is much lower. The most dramatic differences with diabetes, with a high cholesterol, with high blood pressure, and just looking at those alone give us the reason to understand why we have to address cardiovascular disease and why we not only address the cardiovascular disease themselves, but we also have to address those common associated risk factors. Somebody who's depressed, someone who's a current smoker, someone who's physically inactive, and someone who's obese also have an increased prevalence of heart attack. The next slide looks at something similar, looks at stroke. And you'll notice some similarities between the previous heart attack slide and the stroke slide is that someone with diabetes with a prevalence of a stroke at 8, about almost 4 times as higher than someone without diabetes. So once again, from a public health and a private health perspective, we have to think comprehensively about all of the risk factors that a person is faced with. Maybe out in the clinical setting, you may be more in a better position to comprehensively address all of those in your patients, but in some of those things like physical activity and obesity, we may be better situated in public health. But I believe the best way to address risk factors is for all of us to comprehensively look at them together. The next slide is what we use as a framework in Maryland for our Maryland Million Hearts, and it's a framework of partnership. And our staff here in the office, I think, did a really great job of illustrating how we approach a million hearts in the state of Maryland. We have grass tops influences in the grass, on the ground, and grassroots. And so this diagram that we've come up with really looks at the entire infrastructure for the way we approach healthcare here in Maryland. We have the Lieutenant Governor and the Secretary of Health, who are both leaders of the co-leaders of the Maryland Health Quality and Cost Council. That Maryland Health Quality and Cost Council includes senior leaders from healthcare systems, universities, private insurers from many different sectors of the public. But then in the middle, in the grass, we have our mid-level managers. We have healthcare providers, insurance providers, and academic partners that have to take the information that they hear at the Health Quality and Cost Council and take it to their own individual organizations or institutions and talk to their managers about the feasibility of participating. Then we get to the next level where those people that have their boots on the ground, our community and faith-based organizations, our local health improvement coalitions in each county and city in Maryland, our federally qualified health centers, community health centers, local health departments. And then in the grassroots, we actually have to touch the people in each of the populations that are at risk for increased prevalence or heart disease and stroke, and how are we going to approach them. So the Health Quality Cost Council then is a group of healthcare leaders. There are 14 different members in the Health Quality Cost Council, and they represent a variety of sectors in public health, elected officials, private healthcare partners, professional provider associations, their payers, quality improvement organizations, their people in education and business and academia and community health and rural health, and also populations that experience health disparities. The role of the Center for Chronic Disease Control in the Public Health Department is to educate that council on the different various community initiatives and basically on the needs in that particular community. So we have private practice, and for example, we have the Maryland Learning Collaborative, which is the entity in the state of Maryland through the University of Maryland that is educating those patient-centered medical homes. We have our hospitals and medical schools in the state of Maryland we're working with, and we've had discussions about how do we reduce frequently readmitted patients through Million Hearts. We're talking about how do we institute Million Hearts in their grand rounds, in their CME, and in their lectures for both their medical students, their residents, and for their physician faculty in their private practice settings and in their hospital-based settings. We have a worksite wellness initiative, which I'll speak a little more on shortly, called Healthiest Maryland Businesses. And even in the community, we've talked to our medical school about including Million Hearts in their many medical schools they offer for the general population. All of these conversations have stemmed from the relationships that were established through the participation of these entities in the Health Quality and Cost Council. So we also know that in Maryland, that in order to institute a Million Hearts, we have to leverage the resources that we have. We leverage relationships that we have, but then we have to look at where are our funding streams. Where do we have the opportunities where the principles behind Million Hearts intersect with the funding that we have? So in Maryland, we use our preventive health and health services dollars. We funded 5 large jurisdictions with ABC protocols in their clinics, and HIT, community health workers. We did worksite wellness and smoking cessations. We looked at our heart disease and stroke prevention dollars from the CDC to address and promote medication therapy management, which I will again mention briefly again later on in the presentation. We use our diabetes prevention and control program funds to have a Healthy Hearts for Marylanders, FQHC Quality Improvement Initiative, and also we rely very heavily on, in addition, our Community Transformation Grant dollars to address tobacco cessation, healthy eating, and active living. So in consideration for this, we look at how do we create local public health action. Dr. Herrera mentioned our SHIP, our State Health Improvement Process, which is a framework that the state of Maryland uses for shared accountability and integration across public health activities and local activities in the community. There are 39 outcome measures, and the targets include reducing heart disease death rates and reducing hypertension-related emergency department visits amongst those 39 measures that we use. The picture you see on the screen is a picture of a work site out in the eastern shore of Maryland that is promoting walking at lunch. And so we believe if we're going to prevent a Million Hearts, like that birthers risk factor slide that I showed, we have to address it at a prevention level, we have to address it at a screening level, and we have to address it at a prevention level. Now, the graph that is before you includes the counties or the local health departments on the top of the slide, going across the top, On the left side, there are SHIP, or State Health Improvement Process, health outcomes, and health determinants. Then there are the priorities that are included in each of those health outcomes and determinants. And then we look at the synergy between our Million Hearts initiatives and our community transformation grant strategies. So just as an example, if you look at cardiovascular disease, which is the second one down under behavioral health, it shows across with comprehensive medication therapy management, many of the counties have checked in their own local determination of what are their health priorities in their jurisdiction. They selected cardiovascular disease and hypertension. Some of them checked obesity, which is the first one that is in the aqua blue color. Many of the counties across the state of Maryland identified obesity as a problem, as a health determinant that they wanted to address. And our job at the State Health Department is to figure out how do we actually help them to not only think about it, to review the data, but then to implement initiatives that will help them to address those. Maryland also has an infrastructure for local health improvement coalitions. Those local health improvement coalitions, there are 18 across the state of Maryland. They're comprised of representatives from local health departments, hospitals, businesses, education, human services, mental health, housing, land use, planning, and other community-based organizations. 7 of those local health improvement coalitions prioritized cardiovascular disease and hypertension. Once again, understanding that if we're going to reduce the number of heart attacks and strokes across this country and in your jurisdiction and in your state, each of these individuals has a stake or a horse in the game. If you just think about mental health for a moment, that probably over 40% of all tobacco products that are consumed in the United States of America are consumed by individuals with a behavioral health or a mental health background. Smoking rates amongst individuals with mental health issues are at 70%. Individuals with a substance abuse background smoke in the 40% level. Now we know smoking rates in the general population are about 18 to 20%. And so just looking at mental health alone, we understand that if we're going to prevent heart attacks and stroke in that individual population, we have to comprehensively look and address, as I mentioned, tobacco. So we in the state of Maryland have Million Hearts tools and resources that we provide to individuals and entities and corporations and governments and businesses and health departments across the state of Maryland. That implementation guide, which I'll show you a clip of in the next slide, looks at how we align our state efforts so we're all singing and dancing to the same tune. It provides strategies that our partners can participate in. It has metrics included in it, and it gives guidance in 5 core components: local public health action, public health and healthcare integration, expanding HIT, worksite wellness, and promoting team-based care. Now, this is a busy slide, but we wanted to just give you a screenshot of our implementation guide. It includes strategies on the top left. The second one are which potential partners could implement or use those strategies, what are the metrics that they should consider collecting if they're going to implement that strategy, and then there are links to guidance documents that give them the evidence behind each one of those individual Million Hearts strategies. In this one at the top in the purple are Million Hearts Strategic Direction number 1, improve the quality of clinical care for populations with the greatest chronic disease burden and risk through aspirin use for both those at risk, blood pressure control, cholesterol management, and smoking cessation. Now, in addition to that, as Dr. Whatley mentioned, we had a Maryland Million Hearts Symposium. What you see on the right side of your slide is some Maryland Million Hearts hypertension fact sheet that we put together to hand out to participants who participated in the symposium. So the Center for Chronic Disease Prevention and Control here at DHMH, we co-hosted this event with within DHMH and with Delmarva. As Dr. Whatley mentioned, we had almost 400 participants, healthcare providers, pharmacists, healthcare professionals from all different levels in our country, employers, health educators, and CHWs. We had sessions on implementing a Million Hearts in schools and child care settings, work sites, healthcare community, and the hypertension fact sheet that you see talks about hypertension control rates by insurers, hypertension prevalence, risk factors, heart disease, stroke mortality rates, racial, geographic, and age disparities. Now, I will state that in the session implementation settings, we do talk about schools and child care, which we do a significant amount of work through our Community Transformation Grant, understanding that in order to reduce heart attacks, strokes, and cardiovascular disease in the future, we have to address physical inactivity, obesity, and poor dietary habits in our child care and in our school settings. The next slide, moving forward, looks at a newsletter that we've put together called our Maryland Million Hearts newsletter. We distribute it monthly. Our staff here in chronic disease, we have a network of partners which includes 450 individuals. Most of the partners we have, we developed our list of individuals interested in Million Hearts by those who participated in the symposium. So we started out with the Health Quality Cost Council, which gave us the access to many different groups in many different planes across the state of Maryland. Then we have a symposium where we brought those individuals together. We have our state health improvement process and local health improvement coalitions. Then we reach out to all of those with this monthly electronic newsletter. We connect and engage our partners, and we advise our partners about recent research, resources, webinars, and events that are being held. In addition to that, we also have a statewide nutrition initiative as supported by Governor O'Malley and his wife. And the screenshot you see on the left side, it's Chop Chop Maryland. It was a welcome by First Lady Katie O'Malley, who thanked families for joining the governor and his family for finding out fun ways to cook nutritious meals with their family members. And this is distributed monthly. They're healthy, family-friendly recipes and ingredients. We featured Maryland farmers, and we even had a hospital in the state of Maryland, Deer's Head Hospital, which every month serves the Chop Chop recipe that's listed in the magazine. And then we reach out to our Minority Outreach Technical Assistance, or MOTA groups, which are our groups across the state of Maryland that represent minority populations, and we promote and have conversations with them also about promoting their use. We also promote Million Hearts through our Quit line. The callers to our Quit line, 5.8% of our callers have coronary artery disease, 10.6% have diabetes, 15% asthma, and 12% COPD. But we do know that as we're looking at just what is the role of tobacco in Million Hearts, the graphic you see before you, 7.3% of current smokers have had a heart attack in comparison to 2.2% who've never smoked. 3.7% of smokers have had a stroke compared to 1.6%. There is a need for all of our organizations, both public and private, to address tobacco cessation if you want to effectively reduce the number of heart attacks and strokes in your jurisdiction. So with our Quit line, we have privately insured, individuals insured by Medicaid, Medicare, uninsured, and some who don't disclose. So we provide services to a broad perspective of individuals in our state. Most of the individuals have heard from family and friends, some from TV commercials, and we thank the CD with their Tips for Former Smokers campaign. Our rates for callers calling into the Quit line goes up by 300 or 400%, which is a good thing. And we also have healthcare providers which can fax in referrals for patients, which a lot of our Million Hearts activities focus on making sure providers understand that they can get permission from a patient and then advise that patient that the Quit line will call them with our fax to assist program. In addition to that, we have a Maryland Million Hearts website that we include all of the information included today we've talked about in our presentation on that website. In addition to that, we look at integrating public health and health care through our managed care organizations. We talked to Dr. Herrera mentioned the results from our HEDIS vendor expected in summer 2014, adding these measures on hypertension and blood pressure control. In addition to that, as been mentioned previously, the Maryland Health Information Technology efforts, which really bridges private, nonprofit, and information and metrics, real-time data on patient demographics from all Maryland 46 hospitals. Every hospital in the state of Maryland has data integrated through CRISP. Over 90 clinical data feeds. Provider and care coordinators are notified when patients are admitted to hospitals for improved coordination of care. And then coming down on my final slides, we have our Healthy Hearts for Marylanders initiative, which works with our federally qualified health centers, looking at how do we increase blood pressure control by quality improvement measures in their institutions. Maryland has an all-payer claims database through our Maryland Healthcare Commission, and we look at how we can help and work through the Healthcare Commission on accessing and planning for that all-claims database, and we envision supporting provider measurements on quality improvement and clinical decisions. And finally, I believe our virtual data unit works across the state of Maryland, across the health departments on community surveillance, data for needs assessments, data for our ACOs, and our health empowerment zones in a warehouse of social economic data pursuant to public health. And our Worksite Wellness Initiative, we have a Healthiest Maryland Businesses. We work with 200 businesses, 265,000 individuals covered by those businesses. We've trained almost 600 individuals in worksite wellness, including the benefits of Million Hearts prevention efforts offered to their employees. We promote medication therapy management here at our own state center. We have a pilot program using pharmacists to look at and review the medications of our employees. We've seen that those who participate in our medication therapy management in those businesses, 88% of participants achieve blood pressure control of less than 140/90. So we work with businesses to help them to achieve Million Hearts initiatives. And we believe that we can change the heart health of the nation together. We can reduce heart attacks and strokes by working with all of these different individuals you see in the circle. And here at Maryland, we appreciate the opportunity to participate today. Thank you very much.
Thank you so much, Dr. Schell, and to all our speakers. So before we go on to the next portion of our webinar, which will be a discussion with Dr. Wright, we do have a poll for our audience. So if you would like to check off what organizations you would most likely partner with to support Million Hearts in your own state or territory, and then we can post the results. I'm seeing the answers come in. In the interest of time, I'm going to just skip quickly to the results, and you can see the organizations that listeners are working with. And at this time, I'm going to hand it over to Dr. Wright, who's going to ask our speakers a few questions, and then we'll open up the lines. And also, as Dr. Wright is having her discussion, please feel free to chat in your questions as well. Dr. Wright? Dr. Wright, you might be on mute.
I am just congratulating our wonderful speakers. A great trio and lots of fantastic content there. So I will pose a couple of questions, and perhaps Dr. Schell, I could start with you. How about 3 or 4 recommendations for other states that might be hoping to implement a Million Hearts initiative at home? What are sort of the top 3 or 4 things you would recommend? Where do they start?
Well, I think the, as you had in your slide, Janet, talking about set a table, I think that bringing people together that may have an interest or a stake, you need some common way to bring entities from inside and outside of public health hospitals, some common denominator. And it's good to start at the top. If you can get the support of your highest elected official in your state or your jurisdiction or your county, it's good to pull those individuals together. I believe it's developing the common themes. And then from the other side, I'd say look at your funding streams with what you're already funded to do in those existing relationships and decide what Million Hearts initiatives can be rolled into your existing funding streams and find some synergy around that.
Terrific. And Dr. Wadley, if I could spring off Don's answer there, I come from a health care world, and I'm trying desperately to live and breathe a new awareness about public health. A public health student, I think I am. But it's recently come to my understanding how disparate the funding streams are for the public health world and for health care. And I'm wondering how those differences play out in bringing the two disparate worlds together. I wonder if you could comment on that. And Dr. Wadley, you might be on mute.
Thank you. I always look for the positive. And when you look at what's happening in healthcare reform, and especially payment reform, for all of those things that we didn't have a funding mechanism before, those group sessions, the home visits, and all of that, there actually could be a way, if we're working together with healthcare, for there to be a funding mechanism. And it would be a shame if they set up a whole new system when public health could provide that. So I actually think, and everyone knows that those budgets have been devastated, that this may be the best opportunity for public health to find that new life, that new revenue funding source, and still be doing population health management.
Fantastic. Thank you. Julia, do we have time for one more question, or are there some from the field?
No, go ahead. I think we have some time.
Well, great. And so, Don, this might be for you, or if Dr. Herrera is still on, you all can decide. Describe for us the efforts that you've made to address health inequities. They're still rampant. And how is your work playing out there?
Hi, this is Laura. So I think for us, there's multifactorial how we're addressing that. I think going back to the infrastructure slide that I shared with all of you, we're using any one or all of those levers to address that with the health enterprise zone. As part of the law that governs their zoning, they are focused on addressing health disparities and health inequities for the jurisdictions defined by contiguous zip codes. In our virtual data unit, they are pulling together all the different data sets that DHMH has and really focusing on ethnicity and race as priorities in those data sets. So if they're not adequately completed, then ensuring moving forward that these data sets are accurately capturing those so that people can mine the data looking at those inequities and address those. As part of our work with the Community Integrated Medical Home, we're working on that. Our MODA that Dr. Schell mentioned in his presentation, and our state health improvement process, 28 of the 39 measures have ethnic and racial data available for them. And our local health improvement coalitions, as Dr. Schell mentioned, they define the priorities for their communities, but many of those communities have disparities that need to be addressed. And not only are they defining the chronic conditions such as hypertension, but then going one step further and addressing the disparities for that disease. So any one of the Million Hearts infrastructure in that circle that we described, almost all of them are addressing health disparities and health inequities in the state of Maryland.
Thank you so much. You know, I have begun to learn the health in all policies phrase, and I see that you're really working on inequities in all policies and in all actions. It is impressive work. Julie, do I have time for one more?
Well, how about this? Operator, would you like to start the queue while Dr. Wright asks her next question?
Certainly, ladies and gentlemen, if you'd like to register a question on the phone lines, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you'd like to withdraw your registration, please press the 1 followed by the 3.
Go ahead, Dr. Wright.
Great. So this one I will throw up for the trio, and that is that I got to go to the Maryland Million Hearts Symposium. Fantastic, alive, vibrant group. But what caught me by surprise were the number of employers, businesses that were there. And I believe that is so essential to action because many of us who are fortunate enough to be employed spend a lot of time at work in addition to some time at home. So I'd like for you all maybe to share a strategy or tip on how to engage the employer community and make their participation valuable.
This is John. I'll take a stab at it. So we have, as I mentioned on our Worksite Wellness Initiative, we try to speak the language of the employer or the business that is before us. And so we understand and discuss Million Hearts with the employers in the context of what is important for them, employees being at work, employees working when they're at work, and employees reducing their cost of healthcare expenses. And so through our Healthiest Maryland Business Initiative, we talk about businesses. We talk about heart disease, stroke, cancer, diabetes, chronic diseases. We provide technical assistance through 8 regional events that are put in different parts of the state. And we have teams that go out and talk about the importance of that healthy workforce and how can they implement those evidence-based strategies. We also work with IWIF here in the state, and we recently had a insurance workers fund. It's a group where we just had a meeting with over 500 individuals talking about the importance of worksite wellness, and we participated as a sponsor for that and also presented. But we try to meet employers where they are. We speak the language of productivity and savings, and we talk about understanding that the population health is improving the population of those businesses. We recognize those businesses with our success stories that we send out, and businesses like to be recognized. We also put our money where our mouth is, where we are funding our efforts in addressing the health and well-being of our 230-some-odd thousand state employees in the state of Maryland. And so with focusing on our Maryland as an employer, focusing on the needs of the businesses, we think that we're able to have a robust discussion and understand how we can help them to achieve their goals and then how we can also achieve ours.
Thank you. Operator, at this time, are there any questions in the queue?
I'm showing no questions on the phone lines.
Okay. There's one question over the chat. With obesity now a classified disease according to the AMA, how does this impact the work of public health departments and the services people get to tackle this problem?
Well, this is Don Shell. I've been talking a lot. I'll talk a little more. Obesity is a major, major risk factor. And the slide that I had up that showed the increased prevalence of stroke and the increased prevalence of heart attack when individuals who are obese. The tremendous opportunity we've had in Maryland to implement the Community Transformation Grant has given us the ability to address obesity from early in life. And I mentioned previously about our work with child care and in school settings to prevent obesity in the future, but also we're addressing obesity in our communities, looking at how each jurisdiction in the state of Maryland is going to implement activities for physical activity, improving food sources. So example, we have a Healthy Corner Store initiative where we're looking at how we can promote store owners to stock something like skim milk, fresh fruits and vegetables. We work with Dr. Gittleson at Johns Hopkins, who has some research on Healthy Corner Stores from Baltimore City. We've taken that to probably 15 other jurisdictions across the state of Maryland to encourage store owners and store managers to stock healthier food items so that residents have an opportunity to purchase healthier food items to address obesity. So we think across the board that we have to take this comprehensive, broad-based approach to obesity, both from increasing activities for physical activity, promoting chop and other ways people can eat nutritious food, and then we have to make sure the employers provide opportunities for people to exercise. But obesity must be addressed if we're going to be successful.
And I would like to add, this is Frida Wadley, that to the previous question also, how do we get employers engaged? And as an employer that will see next year our cost for health insurance for our employees go up 23%. Now is a good time that you can get them engaged. But secondly, addressing obesity, we had a Weight Watchers program on site for our employees. It was very successful. So there's things that employers can do on both grounds.
Great. Thank you so much, everyone. If other folks have questions, please feel free to email me and I can connect them to the speakers. At this time, I want to thank you for joining us today. The presentations from today's webinar will be available on our website over the next few weeks, and please check our newsletter and website for more information. As I mentioned earlier, there is a link to the evaluation for this webinar, and you will also be directed to the evaluation once I close it. Please fill this out as it provides us with useful information for future projects and the upcoming webinars in this Million Hearts series. If you have any questions, please feel free to email me at jschneider@astho.org. Again, I would like to sincerely thank the CDC's Division for Heart Disease and Stroke Prevention for sponsoring this webinar, and to thank our wonderful speakers, Dr. Wright, Dr. Herrera, Dr. Wadley, and Dr. Schell. We hope that all of the listeners will use this webinar as a resource and will share the link with others once it's posted. Thank you, and have a great rest of your day.